This is the Emergency Medical Minute, sponsored by Mile High Ambulance.
All right, so today we're going to talk about respiratory illnesses in kids. We're seeing a lot more of it, and so it's important to kind of be able to really understand what are the different things that cause it. So generally speaking, we're talking about kids like 2 months to 5 years old. These are kids who are coming in with cough, they can have wheezing, chest tightness, shortness of breath. And so the question is, what is it, right? So the three big things that you think about are croup, bronchiolitis, and asthma, right? And so differentiating between them is important because that also guides how you're going to treat them, right? So like most common causes for croup are going to be like Parainfluenza, Adenovirus, RSV. Enterovirus is actually really big right now. Bronchiolitis is going to be like RSV and Rhinovirus. Asthma, usually it's environmental factors or like a viral illness of any type with an underlying predisposition. So when you see like croup, the most common kids that are going to get croup are going to be kids between like 6 months and 3 years old, and they're going to come in with what? What are you going to hear from them?
The Barky cough.
Yeah, Barky cough, and then what else? If they're really bad.
Stridor.
Yeah, so that inspiratory stridor picture, right, as that, that inflammation in the upper airway, you get that collapse, and then you get that stridulous sound. With bronchiolitis, you're going to have cough, wheezing, retractions, tachypnea, and these are usually between 2 months and 6 months of age as far as bronchiolitis, right? And it's really driven by the secretions that are coming from their nose and inability to really fully clear those. And then asthma is going to be the same almost as bronchiolitis, and that's why it's really difficult sometimes to differentiate the two. But the treatment for all three of these is a little bit different. So with croup, in mild, moderate, and severe, right? And so generally speaking, for moderate, mild to moderate, those are the folks that are going to be getting like dexamethasone, right? Decadron. How much are you going to be giving of the decadron? Do you know what the dose is? Anyone? So it's 0.6 milligrams per kilogram is the dose that you're going to be giving these kids, and it's going to be oral, right? So although it says it's the IV piece, it's actually an oral, and that's usually for like a moderate kid. Generally speaking, if they're mild, they can do it's just symptomatic treatment with hydration, right? Making sure you help them clear their secretions, and then humidifier in the room, Motrin, Tylenol. For those folks that are severe, what are we giving? Yeah, and what's the reason for giving Racemic epi? At what point would you really want to consider that? Yeah. So stridor at rest, right? So like if they have a lot of stridor at rest, that's telling us this is pretty severe. And we have scales that we use. There's a thing that's called the Westley Croup Scale. So like just take a look. It's pretty easy to go through that, and I can give you an idea of where.
Chest X-ray, you get what's called a steeple.
Yeah, so if you did get a chest X-ray, it'd be a steeple sign. Generally speaking, chest X-ray is usually not necessary, right? Radiation in kids, we're trying to avoid that if we don't really need to. But how is Racemic epi dose? This is really important. It's mil per kg, right? So it's 0.05 mils per kg. And so it's really important that you remember that, and you put that in with your 3 mils of solution and nebulize that. And these kids, once you give them Racemic epi, you're going to watch them as well, right? They're requiring multiple doses, right? Then you're probably going to admit them. And then the other thing to think about with these kids also is if you're giving them multiple doses and they don't seem to be significantly improving in between, high flow, humidified, cool oxygen it can be really helpful, right? Because the idea is you're stenting open those airways and helping them with that laminar flow. Heliox is another thing that we can use with these, right? Because it's all about laminar flow of air through their trachea. That doesn't work, then sometimes if they're really working, you'll end up intubating these folks. Bronchiolitis. So what do you guys do for bronchiolitis? What can a nurse do as far as these go?
Suctioning.
Yeah, good deep suction, right? So you can get that tube down on a really small kid, right? Because kids are not obligate nasal breathers, right? So really getting that deep suction can help with this bronchiolitis. Giving them, oxygen as supportive treatment is important. These kids, a lot of times, when they come in and when they look bad, it's actually because they're super dehydrated. And so IV fluids can be a mainstay for these kids that are dry. And you'll see you give them IV fluids and all of a sudden they're a new child, right, with some Tylenol and Motrin. And then the last real piece on this is like a hypertonic saline. Are Nebs useful in these kids? Well, it's not, like where asthma is that, that inflammatory and reactive piece. You're not really going to get a response with nebulizers, and so the data on it actually does not support the use of nebulizers. So generally speaking, they're really not going to help other than agitate the kid by putting a mask on them and really pissing them off, right? And then that makes the rebreathing worse. So then, as far as asthma goes, right, this is the mainstay. It's no different really than adults. Your beta agonists, your steroids, your protropium. So it's going to be DuoNebs, steroids, and then support. Mag is also something that we use, and the idea is that it relaxes smooth muscle. So there's decent data for that in asthma. Not amazing data, but there's decent data for that. So the biggest takeaway from this is really when you get these kids that are coughing and wheezing is first differentiating, okay, well, am I dealing with croup? Am I dealing with bronchiolitis? Am I dealing with asthma? And then tailoring the things that you're going to do and knowing that these are the things that you're going to end up needing to do and that can be helpful, and actually being proactive with it versus saying, waiting for someone to tell you that you need to do it. It's important. And the Racemic epi piece is also really important, and remembering that you can really screw up the dosing, and that's why you have to really remember your mil per kg, and really making sure that you're on top of that.
We'd like to thank our sponsor, Health One Continental Division, and Swedish Medical Center for their financial contributions to the EMM. Donations from them and listeners like you make it possible for us to fulfill our mission of producing and spreading free medical education to the masses. If you enjoy our show, please consider making a one-time or recurring donation to help cover our operational costs and keep the EMM awesome. Click on the link in our show notes to make a donation. Thank you for listening.